Good afternoon, I'm Devangi Joshi and I'm here to present a case study on ocular ischemic syndrome. It's more than just meets the eye. It is rare, it is a potentially blinding condition with an estimated occurrence of 7.5 cases per million people per year. It's quite rare. So it occurs due to hyperperfusion of the eye because of internal carotid or ophthalmic artery occlusion or stenosis. It manifests acutely as sudden diminution of vision or transient ischemic attacks and chronically as gradual vision loss or orbital pain. It can also have varied manifestations like retinal ischemia, neovascular glaucoma, and anterior segment ischemia. Apart from ocular symptoms, it is at risk for cardiovascular attacks and cerebrovascular attacks. The clinical signs are important in OIS. The anterior segment signs and the posterior segment signs are written here. Further evaluation was FFA, ERG, VEP, etc. Carotid Doppler imaging helps clinch the diagnosis. Management should be done with a multidisciplinary approach with coordination with neurologists, cardiologists, and vascular surgeons to treat the causative factors. In our case study, the patient came with a marked vision loss, angle closure and NVG at an IOP of 8, and there was no clear cause for the NVG on an ocular examination, so our field of scope had to be broadened to diagnose the patient. This is a case report of a 65-year-old male who presented with painless, gradually progressive diminution of vision in the right eye. He had a known case of diabetes mellitus, hypertension, CKD, and CAD, and with a history of smoking. In the vision, the right eye was finger counting at 2 meters with no improvement on pinhole. In the anterior segment, as you can see in the photo, there was conjunctival injection, centroclear cornea, 270 degrees of fluorid NVIs with ectropia on UVA, quiet anterior chamber, mid-dilated pupil, posterior synechia, and asymmetric cataract. The left eye anterior segment was within normal limits. The gonioscopy in the right eye was all the angles were closed, as is depicted in here, superior angle. The fundus photo through a hazy media is depicted here with the cup was CDR of 0.8:1 with inferior notch and discal laterals. There was arterial attenuation with venous dilatation, and a few retinal hemorrhages were present in the mid-periphery. In the left eye, there were a few corneal spots, but the disc was within normal limits. An area of blood tests were done which revealed hypercholesterolemia but nothing else, which helped us to rule out CRVO. In carotid Doppler imaging, we found complete occlusion of the right common carotid and the external. So this helped confirm our suspicion of ocular ischemic syndrome as the cause of neovascular glaucoma in this patient. The patient was referred to cardiology where he was started on anticoagulants. From our side, we gave him 1 dose of intravitreal ranibizumab, after which complete regression of NVI was seen. Further, the patient was planned for, the patient underwent phaco with iris hooks and PCI was implanted. The vision improved till 660. The patient also, since the patient showed signs of ischemia with closed angles on gonioscopy and NVI and in CDR of 0.8, we thought of it was neovascular glaucoma. But since the IOP was so low, we needed further investigations. Possible explanations for this was ciliary body ischemia and reduced aqueous humor production because of hyperperfusion. So on Doppler, we found it was OIS. Prompt diagnosis and timely intervention can restore the sight and even may save the patient's life. Thank you.